This is Dr. Dennis James Absin, and we will be discussing the module on sick neonate. So we cannot overemphasize the importance of having a good maternal history in anticipation for possible problems that may be encountered once the baby is delivered. So we have here listed some of those factors associated with high risk pregnancy. So we have economic, in the presence of poverty, unemployment, no insurance or underinsured, and poor access to prenatal care. So, if a mother, a pregnant woman, does not have good prenatal care, then we are not able to determine a right history and we're not able to predict the risk level. Cultural and behavioral factors that may be also associated with having high risk outcomes would be low educational status of the parents, poor healthcare attitudes, no care or inadequate prenatal care, cigarette, alcohol, or illicit drug use, maternal age of less than 20 or more than 40 years, unmarried, short interpregnancy interval. We're talking about less than 18 months between two pregnancies, lack of support, stress, and black race. We also have biologic and genetic factors as listed. We have previous low birth weight or preterm infant, low weight for height, poor weight gain during pregnancy, short stature, poor nutrition of the mom, consanguinity, intergenerational effects, low maternal birth weight, maternal obesity, and hereditary diseases. Reproductive factors are also listed here. As you can see in your screen, we have here previous CS, infertility, conception by reproductive technology, prolonged gestation, that's more than 40 weeks, prolonged labor, a previous infant with cerebral palsy, intellectual impairment, birth trauma or congenital anomalies, abnormal lies such as in breech presentation, multiple gestations, because we know that multiple gestations would tend to be delivered prematurely. Premature rupture of membranes as a risk factor for development of neonatal sepsis. Presence of infection in the mother, it may be systemic, amniotic, extra-amniotic, or cervical. Hypertension, uterine bleeding, parity if first time or with more than five previous deliveries, uterine or cervical anomalies, fetal disease, and high or low levels of maternal serum alpha fetoprotein. You also have medical conditions of the mother associated with factors leading to high risk pregnancies, such as gestational or maternal diabetes mellitus, hypertension, congenital heart disease, and so forth. So once a baby is delivered, okay, so it's very important that we have a thorough history taken prior to delivery. So we are able to anticipate potential problems that may occur. A maternal condition may lead to a neonatal complication. Although most newborns make the cardiorespiratory transition to extrauterine life without intervention, still, many will require assistance to begin breathing, and a small number will require extensive intervention. So, after birth, approximately 4 to 10% of term and late preterm newborns will receive positive pressure ventilation or ambu bagging, while only about 1 to 3 per 1,000 will receive chest compressions or emergency medications. So majority of babies delivered tend to make the transition from intra to extrauterine environment a smooth process. But a good number of babies delivered would need rather some form of assistance, and most commonly this would involve positive pressure ventilation. So our goal in dealing with deliveries, whether high risk or low risk, is to make the transition from intra to extrauterine environment a smooth process. When a newborn requires resuscitation, it is usually caused by a problem with respiration because most of them would have normal hearts. And the problem really lies with the respiratory system, leading to inadequate gas exchange. So, respiratory failure may occur either before or after birth. Before birth, the fetal respiratory function is performed by the placenta. So, the fetal lung does not primarily exist to function for gas exchange. If the placenta is functioning normally, oxygen is transferred from the mother to the fetus and carbon dioxide is removed. When placental respiration fails, the fetus receives an insufficient supply of oxygen to support normal cellular functions, and carbon dioxide cannot be removed. So the blood level of acid increases as cells attempt to function without oxygen and carbon dioxide accumulates, leading to metabolic acidosis. And subsequently, fetal monitoring may show a decrease in activity, loss of heart rate variability, and heart rate deceleration. So you will have at this point, if there is not a good respiratory function secondary to blood flow from the placenta, you will have fetal distress. If placental respiratory failure persists, the fetus will make a series of gasps followed by apnea and bradycardia. So that if the fetus is born in the early phase of respiratory failure, tactile stimulation may be sufficient to initiate spontaneous breathing and recovery. So we call that primary apnea if a newborn is delivered not breathing adequately or has no breathing effort. And this is reversed just secondary to after application of tactile stimulation. Then we say that that particular newborn is in primary apnea. Okay. And the implication is the 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 newborn was in the early phase of respiratory failure. Now, if the fetus is born in the later phase of respiratory failure, stimulation alone will not be sufficient and the newborn will require assisted ventilation for recovery. And we call that secondary apnea. That means that a patient or a newborn is apneic. However, tactile stimulation will not reverse the apnea, but you still need to do further intervention in the form of positive pressure ventilation. So that is secondary apnea. Now, what is the clinical implication of that? Okay, so if a baby is delivered apneic, sometimes we tend to stimulate the baby in attempt to make the baby cry or breathe. Sometimes you see Sometimes in viral videos, you see babies being stimulated, lasting for a minute, 2 minutes, 5 minutes, okay, just with tactile stimulation. The clinical implication of what we've been talking about is you do not waste time trying to stimulate the baby because you are supposed to assume that that baby is in secondary apnea. The stimulation, the tactile stimulation is supposed to happen only for 30 seconds, after which, if the baby does not respond, you would have to go or provide additional support in the form of positive pressure ventilation because with the presumption that that patient is in secondary apnea and therefore wouldn't respond to tactile stimulation alone, but only with positive pressure ventilation. Okay, so do not waste valuable time trying to stimulate and make the baby cry, even after 30 seconds, so that because that will aggravate the hypoxia, the acidosis occurring at that point. So the most severely affected newborns may require chest compressions and epinephrine to allow the compromised heart muscle to restore circulation. So this is after secondary apnea. So at the time of birth, you may not know if the baby is in an early or late phase of respiratory failure. So primary apnea is in the early phase, secondary apnea is in the late phase of respiratory failure. So we are saying that you presume once the baby is delivered with respiratory failure with apnea, assume that that is secondary apnea, so you won't have to waste valuable time trying to do tactile simulation in an effort to make the baby cry. So after birth, respiratory failure occurs if the baby does not initiate or cannot maintain effective breathing effort. In either situation, the primary problem is a lack of gas exchange, and the focus of neonatal resuscitation rather is effective ventilation of the baby's lungs. Okay, so when a baby is depressed, when we need to do resuscitation of the newborn, it is always ventilation, ventilation, ventilation. We aim to put air and oxygen inside the baby's lungs. We aim to ventilate. That is the primary focus of resuscitation of the newborn in the delivery room. So we have here a diagram of the fetal circulation path. So we know that only a small amount of blood travels to the lungs in in the fetus, in the fetal stage, and there is no gas exchange in the fetal lung. So blood returning to the right side of the heart from the umbilical vein has the highest oxygen saturation. After a baby is delivered, we have the transitional circulation pathway. So upon delivery, the baby breathes and pulmonary vascular resistance decreases and blood travels to the lungs for gas exchange. And blood returning to the left side of the heart from the lungs has the highest oxygen saturation at this point. So these are the physiologic events in the transition from fetal to neonatal respiration. So the change at birth, we have the babies would start to breathe. The umbilical cord is clamped, therefore separating the placenta from the baby. And the effect would be the newborn is now going to use the lungs instead of the placenta for gas exchange. Second event is fluid in the alveoli is absorbed. Okay, upon the baby's crying and breathing, air replaces fluid in the alveoli. Oxygen moves from the alveoli into the pulmonary blood vessels, and carbon dioxide moves into the alveoli to be exhaled. And the third physiologic event in the transitional state from fetal to neonatal respiration is air in the alveoli causes blood vessels in the lung to dilate. The net result would be pulmonary blood flow increases. So you have a decrease in the pulmonary vascular resistance, and the ductus arteriosus gradually constricts. So this is just a diagram of the air replacing fluid in the alveoli upon delivery of the neonates. So fluid fills the fetal alveoli upon the crying and the breathing of the newborn. Air would now displace the fluid inside the alveoli. In terms of the vascular bed in the pulmonary blood vessels, they would now dilate secondary to the breathing and opening of the alveoli. So, in the fetal circulation, you have constricted blood vessels, that's before birth, and upon delivery, with oxygen, with crying and breathing of the baby, and air going into the alveoli, there are going to be dilated blood vessels upon delivery, and air is going to be seen or present in the alveolar level. So that is previously that was the physiologic transition that occurs during delivery. So how does a newborn respond to an interruption in normal transition? Now, if there is an interruption in either placental function or neonatal respiration, gas exchange within tissues is decreased, and the arterioles in the intestines, kidneys, muscles, and skin may constrict. A survival reflex maintains or increases blood flow to the heart and brain. This redistribution of blood flow helps preserve function of these vital organs. So if you've heard about the diving seal reflex, In cases of hypoxia, there is going to be preferential distribution of blood to the vital organs, and these vital organs are the heart, the brain, and the adrenals. So that's why in prolonged hypoxia, you will see damage to the other organs, which are not preferentially um, perfused. So in the intestines, you can have necrotizing enterocolitis after hypoxia. In the kidneys, you can have acute renal failure, and so on and so forth. If inadequate gas exchange continues, the heart would now be affected and begins to fail, and blood flow to all organs would decrease. And the lack of adequate blood perfusion and tissue oxygenation interferes with cellular function and may lead to organ damage and finally to death. So these are the clinical findings of abnormal transition. So if the transition from intra to extrauterine environment, as we've said, is not smooth, these are the things that may happen and you would see clinically. So you can have irregular or absent respiratory effort or apnea or rapid breathing, tachypnea. You can have slow heart rate, that's bradycardia, or rapid heart rate or tachycardia. Decreased muscle tone, so a baby may be delivered limp. You can have low oxygen saturation, and you will see the baby to be cyanotic and with low blood pressure or hypotension. So this, in addressing all of those problems, in addressing to the complications that may occur during delivery, uh, that is actually the point of NRP, or the neonatal resuscitation program. So as we've said, as we've discussed earlier during the prematurity module, this is a series of interventions and evaluation to address the complications and the problems that may be encountered upon delivery. So the latest edition we have is the seventh edition. This was published in 2016 by the American Heart Association and the American Academy of Pediatrics. And this is the global recommendation in dealing with delivery of newborns. As we've said earlier in the past lecture, in the Philippines, we are adopting this and we incorporated, because we call it the NRPH Plus, we incorporated the kangaroo mother care and the essential intrapartum newborn care. So basically, the neonatal resuscitation program, or the NRP, consists of the following. We have the initial assessment to determine if the newborn can remain with the mother or should be moved to a radiant warmer for further evaluation. And in resuscitation, we still follow the ABCs. Okay, the first is airway. So perform the initial steps to establish an open airway and support spontaneous respiration. Then we have letter B for breathing. Positive pressure ventilation, or ambubagging, is provided to assist breathing for babies with apnea or bradycardia. As we've said, babies in secondary apnea would require positive pressure ventilation to reverse the cessation of breathing, or to stimulate them to breathe again. Other interventions may include, for breathing, CPAP, or continuous positive airway pressure, and this may be appropriate if the baby has labored breathing or low oxygen saturations. Then we have circulation for letter C. If severe bradycardia persists despite assisted ventilation, circulation is supported by performing chest compressions together with positive pressure ventilation. And finally, if severe bradycardia persists despite assisted ventilation and coordinated compressions, drugs may be given in the form of epinephrine after or as PPV and chest compressions continue.